Good morning, everybody. Welcome to this month's Monty Heart. We are very excited to have with us Dr. Zola Dandu from Ochsner Medical Center. He has done his residency and fellowships from Ochsner and is now the section head of Ochsner Kenner campus. And he has a special interest in PAD as well as in limb salvage and preventing of amputations. So we are very excited to have him. And this comes right on the heels of Best CLI trial, which was long awaited in our community and might change the paradigm of below the knee revascularization. So welcome, Dr. Dandu, and please take it from here.
Okay, well, thank you very much for having me today to join you. I come to you by recommendation of one of our former fellows, who was a former fellow as well, who did general cardiology with us and came to do intervention with you in New York, Dr. Bob Manuel. And I also knew Dr. Jose Wali. I met him many, many years ago. I was an intern. He was a first-year interventional fellow. So it's been a very long journey. Thank you much for the invitation. And these are my disclosures. I consult with some companies regarding in the space of PAD, but really what I like to share with this picture is my neighbor's dog. So I have 4 kids. They play football, all kinds of sport in the backyard. Every time the ball goes to my neighbor's yard, this is what the dog does to the football. So I always tell people this is how I feel about amputations. And so today we're going to talk about revascularization strategies and chronic limb-threatening ischemia. How aggressive should we be to establish inline flow to the foot or to the wound? So, and as mentioned earlier, this come as we just published our best CLI. So PAD, why does it matter? Because this is a global problem with over 200 million people worldwide being affected by this. The statistics in the US are approximately between 8 to 10 billion people being affected. At some point in time, about 11% or so are going to be dealing with CLTI. What's really important about this, besides the numbers, is the costs. We're talking the illness that costs approximately, the number varies between $15 and $20 billion yearly, which is probably more than some countries' GDP. And 20% of patients with peripheral arterial disease are polyvascular. And so that's important because we come across these patients. They have coronary disease, they have cerebral vascular disease, and those are peripheral arterial disease, sometime in combination, sometime in isolation, but they'll have the same risk factors. So it becomes extremely important how we treat these patients and how we manage them. And as you look at the risk factors, so we have diabetes, and this is a whole spectrum that leads to CLI and unfortunately at times leads to limb loss. So you have diabetes, which affects 26 million folks in the US, so 8% of the population. You have peripheral arterial disease, about 15 million. You have peripheral neuropathy, you have foot ulcers, critical limb ischemia, and ultimately limb loss. The majority of patients with peripheral arterial disease are asymptomatic, and so that's where it becomes very difficult in terms of education, prevention, which will be cost-effective versus some of the very expensive work that has to happen as these folks develop wounds needing revascularization and multiple hospitalizations. So if we just go by claudication, we get to miss a large percentage of our patients. And when you look at this graph, patient presenting with PAD, a symptomatic patient range between 20 and 50%. A typical presentation between 40 and 50, somewhere in that range, and claudication or worsening claudication is between 10 and 35%. And what I have, where the arrow is pointing, that's the 1 to 2% of folks that will develop critical limb ischemia. So it's a very small number. However, that small number is very costly and associated with a higher mortality. And so when we talk about chronic limb-threatening ischemia, the definition is rest pain, tissue loss, or gangrene over a period of 2 weeks. Classification, we use the Fontaine classification. For rest pain, it's classification 3. And for when you start developing tissue loss, is Fontaine 4. We have referral classification that goes from 1 to 6, but we use 5 and 6 when people have minor tissue loss, and 6 when they have gangrene, 4 still rest pain. And then we have the WIFI classification, which I think is great because it's a system that combines both wound, ischemia of the foot, and foot infection. And with that, it gives you a spectrum as to what the patient could have and how can we go about assisting them if we can. When we look at objective evaluation of CLI, in addition to obtaining things like Doppler ultrasound that might show us the anatomy, CTAs or MRA, ankle breaker index comes in handy, less than 0.4 or absolute highest less than 50 millimeters of mercury. Toe breaker index, especially in our patient population where the ankle breaker index could be abnormal because of medial calcinosis. And then a toe breaker index is very helpful. And we know a toe breaker index of less than 30 to 40 millimeters of mercury is associated with less likelihood of healing a wound. The other thing that works very well is transcutaneous oxygen oximetry, where in short we call it TCPO2 or TCOM. And if it's less than 30, then we know that particular patient might have challenges healing a wound. You can also do skin perfusion pressure, which is also very helpful. The issue with CLI is it's the most advanced form of PAD. So we mentioned earlier, 1 to 2%. You can see the annual incidence. But the issue is it's associated with a very high mortality and morbidity. And the one way to simplify it is when I meet patients, I usually present them what I refer to as the rules of quarters. And so in that rule, what I explain to patients is 25% of patients who present with CLI are going to be dead within a year. 25% are going to be amputated. And of the remaining 50, if you split that in half, 25% of them are going to have a limb with a wound that has not healed. And the other 25% are going to have a wound that's completely healed. And so I always tell patients, you want to be in that 25 that's going to get better. Obviously, we're working very hard, multiple specialties with industry and research, trying to improve those numbers. As of now, this is what we have. So it's a very deadly disease. This is a paper that was published by a colleague of mine, Dr. Jihad Mustafa, a couple of years ago in 2019, comparing CLI or CLTI to many cancers. And when you see in red, that's critical limb ischemia. And when you compare, the only cancer that has a higher mortality over a 5-year period from the time of diagnosis is lung cancer. So the idea that breast cancer, colon cancer, or HIV or melanoma has less mortality than CLTI is very shocking to some people, but it's a reality that we face. So it's extremely important for us in the field, in the medical community, to educate ourselves, but also the community at large, to make sure that we can make changes with this illness. And so this is a slide that I really enjoyed, and I always like to talk about this, talk about the impact that the breast cancer community has had in terms of getting awareness of the illness. So on the far left, that's the South African national cricket team. All in pink, you have the Eiffel Tower, you have the White House, you have NFL cheerleaders. But when you look at this graph, it shows the 5-year mortality when you compare CLI to many other illnesses. Breast cancer is approximately 11%. But when you look at Charcot foot, it's already almost doubled. When you look at diabetic foot ulcers, when you look at minor amputation, when you look at CLTI, when you look at major amputation, all of them much higher. But we hear more about breast cancer. So perhaps we all should get together and be able to have the same impact in terms of awareness and educating the community at large about the morbidity and mortality associated with CLTI. The natural history of PAD, as you can see from a morbidity standpoint, as I mentioned multiple times, 1 to 2%, you have stable claudican, you have worsening claudican, but that 1 to 2%, very, very high mortality and morbidity, and a high number of the cardiovascular events that they have are usually MIs. And so extremely important as we treat this patient to make sure that they're getting guideline-directed medical therapy, and it could also be an opportunity to screen them for coronary disease as well, to treat them, whether it's an echo, whether it's addressing the smoking, whether it's addressing the diabetes, and all those kind of things which are extremely important. This is a slide from a paper that was published in 2011, so quite some time ago. Hopefully things have changed, but just showing the 30-day mortality and morbidity associated with major amputation in CLI patients. So 4,250 patients with major amputation between 2005 and 2008. And they were looking at below knee and above knee amputation. As you can see on the left, the mortality when you compare the two. So just having an above knee amputation in itself is associated with a higher mortality. When you compare it to below knee amputation. When you look at wound infection, AKA, wound will heal very faster than the VKA. And then when you look at stroke, it's also higher with above knee amputation. So amputations are not benign. Whatever we can do to prevent these folks from getting there is extremely important. And then we also know there's a geographic clustering of diabetic lower extremity amputation in low-income areas and rural areas. This happens to be a paper talking about some numbers in California. And if you look at the graph on the right, they're looking at different counties, and they look at the income level in those areas. As you can see, as the income level drops, as you go towards the far right, the level of amputation goes up. When you compare Malibu to Compton, it's almost a 10 times fold increase in amputation. And so what they've noticed is in some region, in some hotspots, especially in low-income urban and rural area, the amputation rate is almost 10 times higher than others. So it's extremely important to make sure that we reach, especially to community that are at risk, to educate them and hopefully prevent things like this from happening. Another paper out of California published in May 2019 that talks about the shameful metric of inadequate care when it comes to diabetic amputation. So what they did, they looked at 82,000 diabetic amputation between 2011 and 2017, and they broke it down by age and by race. So when they looked at age, they looked at 45 and 65, so that's working age, and above the age of 65. And when they looked at, as you can see the graph in purple, that's Black, in blue, Hispanic, in green at the bottom, white. So when they compare, you can see that the rate of amputation or the likelihood of getting amputated is 2 to 3 times higher just by race. And as you get older, same thing, the gap is even wider. So we have a lot of work to do in that regard to address these inequities. And really what helps to address CLTI is to work in a multidisciplinary team setting. And that team really encompasses multiple specialties. That includes wound care and the folks that will do the debridement, advanced reconstructive surgeries, minor amputation, offloading pressure, endocrinologists, nephrologists, podiatrists, internists, emergency room, urgent care, infectious disease, smoking cessation. And the one thing at times we don't mention very much when we talk about the team setting, we don't talk about the patients and their families. It's not possible to succeed in treating any of these patients if they can't make it to their appointments. So many of them are debilitated, so they depend on their families. So we always make sure that we incorporate them in that team setting. That way we can have a successful story. And the benefit of these teams are patients can get comprehensive care because you have multiple specialties. There's collaboration across specialties, decreasing the barriers. It allows everybody to share the knowledge and ultimately to benefit the patient. Patients are lucky in a sense when they're treated in the team setting because they get to benefit from advanced therapies. And revascularization is the cornerstone of treating CLTI in obtaining inline flow to the wound. That can be done surgically in patients that can tolerate the stress of surgery, but also a patient with good vein conduit and also target where the bypass can be attached to. Endovascular options definitely there. And over the past several years, there've been a lot of advance in endovascular therapy, but also hybrid. Sometimes we can combine the two treatment option, which means it's extremely important to work in a team setting where a vascular surgeon, an interventional cardiologist, an interventional radiologist can all work together. A podiatrist can work together. So I think it's very beneficial to our patients when we can provide the care in the setting. This is courtesy of a colleague, Dr. Roberto Ferrasi in Italy, and he's an angiologist, and all he does is treating patients with critical ischemia. And they looked at patients between 2010 and 2013, 1,449 patients with Rutherford 5 and 6. It was an interesting observation that he noticed. What they noticed was the majority of the patients presenting with diabetic ulcers in CLI have predominantly infrapopliteal and inframalleolar disease. As you can see, 5% in the iliac and CFA, 60% in femoral popliteal area, 90 below knee, and 80 below ankle. And so it becomes extremely important as we treat these patients to make sure that we can assure they have adequate inflow, but also adequate outflow to make sure we can get blood to those wounds, for those wounds to heal. And so I have a couple cases I'm going to present you. Hopefully, we're going to have a great discussion afterwards. So this is the gentleman who's 68 with hypertension, hyperlipidemia, insulin-dependent diabetes, coronary disease, sleep apnea, asymptomatic PAD. So for years, never had any problems, didn't know he had CLI until the index presentation. He was gardening, had a traumatic event to his toe, and before you know it, he's having a wound that's not healing, 4 out of 10 rest pain. By the time he presented to our center, this was 2 months into his illness. As you can see, we did tissue oximetry, and the dorsal of the foot was 22 millimeters of mercury, and the medial ankle area, the posterior tibial, was 30 millimeters of mercury. So he had an unsuccessful revascularization, so then he was sent to us for another attempt. And what we have here is inflow was adequate in terms of his aorta and common femoral. His superficial femoral artery on the left looks open, popliteal looks great, but then he has infrapopliteal disease. In red is what's missing. So he has a proximal short occlusion of the anterior tibial. You have reconstitution of the proximal anterior tibial by this diffusely disease, and the mid anterior tibial is completely occluded. In the middle there, you see the TPT trunk that's open, but there's some disease there. The peroneal is completely occluded. Posterior tibial is occluded by reconstituted from geniculate collaterals. And the intervention that he had was the cross with a lot of difficulty, the peroneal artery, balloon angioplasty. But unfortunately, by the time the patient presented us within a week, that peroneal artery had already occluded. So this patient needed some extra help. When you go lower towards the foot, you can see the posterior tibial will constitute, you see the peroneal, and you still the distal aspect of the anterior tibial in this lateral view of the foot. But what you see here is the posterior tibial is occluded. You see reconstitution of the medial plantar, and in red is the lateral plantar, which is occluded, and that's what's going to connect with his anterior tibial and dorsalis pedis. In this view, it's very difficult to see, but when you go to the AP view, you recognize that circle where I circle the posterior tibial, you see the part of the lateral plantar that's open, and in blue is the continuation, that's what's open. What's missing is when you look at the anterior tibial, you don't see a dorsalis pedis making a connection for interplantar loop. So these are patients at times when we don't treat them, they end up getting into trouble. So we thought we can help this patient after having a multidisciplinary discussion with the referring hospital that sent him and our local colleagues. So we got a wire down to the posterior tibial, we got to the ankle, and we could not advance any further. So we couldn't cross this area to provide flow to the foot to hopefully heal his wound. So we tried multiple techniques, unfortunately it did not work with multiple wires, multiple catheters. So then we stopped. One option was to completely stop the procedure. The other option was to sit back again with our surgical colleagues and see, is there anything they can offer surgically in terms of a bypass here, whether it's below knee or infrapopliteal or inframalleolar. And the other option was to continue with an endovascular approach and see if we can help this gentleman. But we knew that would require alternative access and crossing techniques. So one option, as I mentioned earlier, was to completely abandon the posterior tibial and put a wire down the anterior tibial so we can make it all the way down to the foot. Option number two, considering there's so much disease in this anterior tibial, can we just get immediately retrograde access in the anterior tibial? And once we cross, reverse our access to make it to the wound. Option three, we thought, how about we get integrate access in that distal anterior tibial and navigate down the plantar loop and connect with the posterior tibial so we can get flow to the foot. And option number four was the hardest one to get into, but of all of them, we're only going to have one CTO to deal with, which will be to get into that small short island of lateral plantar artery and make a connection with a PT and finish the case. So we opted for option number four. We're able to get access in the lateral plantar artery that was open. The patient had a nerve block, so he could not feel anything. We used ultrasound to be able to get access in the foot. And thereafter, we're able to make a connection. We're able to get a wire into the lateral plantar, into the dorsalis pedis. We did balloon angioplasty with IVUS guidance so we can get the proper size with a 2, eventually 2.5, and ultimately 3 balloon. And we use a 3.5-4 balloon in the posterior tibial. And what we end up having is this. We have a small dissection there, non-flow limiting, able to get blood flow to the foot. And the patient did very well. You can see the toe was amputated. He had wound care not by me, but by our wound care team. He had multiple skin grafts and ultimately were able to heal his wound and continue with a very active life. Here we have a gentleman who came to us with a wound that unfortunately started as a venous wound, but unfortunately had a combination of venous and arterial disease. He has a previous history of heart disease, as you can see, cabbage with harvested left greater saphenous vein. So unfortunately, not the greatest surgical candidate in that regard. Hypertension, hyperlipidemia, venous reflux, and peripheral arterial disease. Prior to coming for this particular event, he had a FEMPOP graft with a PTFE from common femoral to popliteal. The distal popliteal was occluded. The vein graft, this graft was filling the mid aspect of the superficial femoral artery. And then distally, he had geniculate collaterals that reconstitute the perineal, which then ultimately gave flow to the distal AT and PT with an intact plantar arch. And all these arteries were heavily calcified. The dorsum, as you can see on TCPO2, is 2 millimeters of mercury. And after we exposed him to oxygen, instead of rising, he went down to 1. The medial aspect was 16. After exposing him to oxygen, he only went up to 27. So even with oxygen exposure and hyperbaric, he was still below the healing threshold. And so this is the anatomy, as I mentioned earlier. So you see the common femoral is open. You see the bypass graft, the PTFE graft. SFA is completely occluded. The ostium is not visualized. In the middle, you see, as the bypass graft crosses, you see the native SFA below. And I have in yellow here just to show you how much calcium there is in this native SFA. So our plan, let me go further down here. So you see the FEMPOP here attaching to the popliteal, but there's no flow below. What's keeping this graft open is the retrograde flow into the SFA, but nothing going on the popliteal towards the foot. So that's what's missing right there, the popliteal. And here, when you look, the popliteal comes in, still missing, TPT trunk occluded, and then both AT and PT are occluded, as you can see in red. And when you go down to the foot, both of them are still missing. And then at the bottom here, you see in the left, the perineal comes back and gives collaterals to both the AT and a branch that will connect with the DP to give an interplantar arch, but not filling very well. So when we brought the patient, the original plan was we're going to go through this FEMPOP graph and trying to make a connection, and then come retrograde to the perineal. Hopefully, we're going to reconstruct it. And that was our plan. Unfortunately, by the time we brought the patient back, within 4 weeks, that FEMPOP graph occluded. And you see the picture in the middle, the second picture, there's a red dot. That's an island or two of SFA that's open, but that's really the only thing we can see here. We cannot visualize the ostium of the SFA. So I spoke with a few colleagues, put some thoughts together, and decided we're going to try to get retrograde access into this SFA. And whether we get intraluminal or subentomal, the idea was just to get into the vessel architecture, advance our wire, and hopefully dissect and make a connection and then reverse our access. So the initial access was obtained, we advanced the wire, but it took a direction we were not quite comfortable. We thought maybe we perforated. So then we obtained a second access. And so that's the second one where you see the arrow. And then eventually we were able to advance that wire in a knuckle fashion, very much like we're doing coronary dissection. And we advanced it all the way to what we thought was the takeoff of the profunda based on the calcium. We then ballooned through that area, knowing that we were subentomal, but we knew that was going to facilitate crossing from our up and over sheath. And that's what we did right there. We're using a Stauder 40 wire to cross. And what it looked like is this. You see the right common femoral access, and then you see the retrograde access in the mid-SFA, and all three were obtained with ultrasound guidance. So then eventually we reversed our access. We went past those SFA access point, but then we also got stuck where we couldn't go any further. So then we obtained retrograde access in the perineal, advanced our wire, and then when we came to the 2 point that we thought we were going to make a connection, we still had incredible difficulty. So here we did a technique called reback, in short for reentry back. So we used a Pioneer reentry catheter, and we had a retrograde balloon that we punctured through. And as you can see, this balloon, it's kind of the top part of the balloon that's retrograde is away from the vessel architecture. So we knew that we had a perforation here But as we're struggling for this patient, we kind of knew this was the only thing we can offer him, and we're going to deal with that at a later time. So the balloon is right there, way away from the vessel architecture. So somewhere in La La Land, we don't know where. And then what we do after puncturing the balloon, we then advanced the wire. So our balloon became the receiving catheter. Then we were able to externalize. And we did IVUS, we did balloon angioplasty, and then ultimately proceeded to stenting. So we have a stent in the proximal SFA. We have a stent here in the mid and distal SFA. And you can see in yellow, that's the area that we got in. We're in a true lumen, and the calcium there was much harder to deal with compared to the calcium in the subintimal space. And picture number 3 shows you the area that we thought we had a perforation, and definitely had a perforation there. Even though we did balloon tamponade and manual pressure, we ultimately had to put a cover stent there to deal with that. And down below, this is what we have. We have now perineal flow all the way down to the foot. We can see opacification of the posterior tibial and branches up front. But we didn't think this was going to be enough. We thought maybe in the future we can bring him back to open up the dorsalis pedis to get better flow to the foot. So we brought him back 6 weeks later, and the flow was much better. His TCOM was much better. So we ended up not doing anything. So opening his SFM popliteal and TPT trunk was enough to get flow, and the patient is doing very well. Here I have a gentleman who's 66. As you can see, there's a theme here with hypertension, hyperlipidemia, and diabetes, CKD3, status post-CABG, and presented with a left grade 2 wound. He's got a cardiomyopathy, and he also never had any claudication prior to his presentation to this traumatic event. His ABI on the right was 0.92, on the left was 0.44. So we knew we had to do some help. He was seen in the multidisciplinary setting. He was not a surgical candidate because he did not have good grafts, even though the greater saphenous on the right could have been harvested to use for his left leg. Unfortunately, that vein graft, that greater saphenous, was less than 3 millimeters. So he was referred to us for an intervention. As you can see on the left, common femoral looks okay, proximal SFA looks okay, mid SFA subtotal, if not 99%. The popliteal is occluded right above the knee. You have geniculate collaterals in picture number 3, reconstitution of perineal, which is also diffusely diseased. And when you go to picture number 4, the perineal halfway through the calf vanishes. Down below, it gives collateral to diffuse disease, posterior tibial and anterior tibial. And the very last picture, you can see dorsalis pedis there, but there's no complete arch. And we know the inflow is compromised by not having a popliteal and TPT trunk. So we brought this gentleman, we got integrated access, we were able to cross the SFA lesion, but we could not even advance the sheath across that. So ballooner initially with a 4 balloon just to make a channel, and subsequently struggle trying to cross into the TPT trunk if we could. It was unsuccessful. So then we decided to get access in the dorsalis pedis, trying to go retrograde. Unfortunately, that didn't work out because we couldn't get our wire to stay true lumen, and we did not want to dissect the TPT because we could potentially lose the perineal. So here you can see picture number 2. We obtained access at the P3 level of the popliteal artery. Patient was still in a supine position. We had the camera in the ipsilateral oblique and 15 degree of caudal. And once we got access, we put a micropuncture. Then we were able to go retrograde and make a connection. We did reverse cart, where we balloon angioplasty on the anterior wire with a 6-0 balloon, and ultimately cross with an astato wire to externalize to complete the case. And what we did here, we did balloon angioplasty, and we removed the retrograde sheath. We did balloon tamponade with a 5 millimeter balloon, ultimately ballooned the popliteal with a 6-0 high pressure balloon because of the amount of calcium there, and put separa stents. And this was our result. Patient went on to do rehab, antibiotics, but unfortunately it was not enough to heal the wounds. So then we brought him back so we can complete the infrapopliteal work. We obtained retrograde access in the posterior tibial and anterior tibial. This time we're able to stay true lumen. As you can see, the 2 sheaths that we have, the one in the PT, one in the dorsalis pedis, and we balloon both vessels after externalizing our wire. He had an extensive debridement to the point where the connection between the anterior tibial and the lateral plantar was disconnected. And so this is the final result with all 3 arteries open down to the foot, and patient went on to heal. This is the gentleman who presented to us just right before the pandemic. He was exercising on a bike. Something happened with his shoes. He continued exercising without shoes and presented with necrotizing fasciitis. So he had to be taken immediately to the operating room for infection control. Then we got involved later. So we took him for an angiogram. We did a right transparator diagnostic. He was morbidly obese, so going femoral was worse than for us to have a complication. And we also did selective angiography of his right leg. And what we have is that inflow was adequate, but when you get below knee, we can see the anterior tibial is occluded. We see there's high-grade disease in the TPT trunk and the multiple lesion in the posterior tibial that don't look significant, but on IVUS they were significant enough. And when you see here in the picture number 3, the posterior tibial gives flow to the lateral plantar and medial plantar, but we don't see much flow in the dorsum aspect of the foot. And with such a massive wound, we thought this patient would need a little more than this. So we decided we're going to do this case with the TAMI approach, where everything is going to be done through his tibials because he's morbidly obese. We want to minimize any risk of having a complication. And this is before some of the things we've learned recently or we've developed in terms of being able to do radial to pedal interventions. So we got retrograde access in the dorsalis pedis, but unfortunately, it's not guaranteed if you go retrograde that you're going to cross and be able to complete the case. So we're able to advance the wire to the proximal part of the AT. Then unfortunately, we couldn't go any further. And so you can see picture number 2, our wire is advancing. Number 3, we kind of make it there, but we can't go any further. But what we didn't want to do here is to dissect further into the popliteal and lose the TPT trunk, which would jeopardize flow down to the foot. So at this point, we decided we needed an integrate access. So we're going to use his posterior tibial as our integrate access. Traditionally, would have had access in the anterior tibial, in the common femoral, but we shied away from that because of his body mass. So our PT will serve as our integrate access. So that's the wire from the PT going to the TPT trunk. After a couple maneuvers, we're able to get this wire to cross from the TPT trunk into the anterior tibial. And then once we did that, we cross over, we are able to advance the integrate wire, and then we externalize. Here you can see a support catheter crossing from the TPT into the anterior tibial. And then here in this video, you can see the integrate wire from the PT going to a retrograde catheter that's within the dorsalis pedis. And the very last picture on the right, our wire is being externalized. So now we will start with Safari with a wire going from posterior tibial into dorsalis pedis and be able to complete the work. We did a atherectomy based on IVUS because the arteries are heavily calcified. Then ultimate balloon angioplasty with IVUS guidance. We used a 3.5 balloon in the anterior tibial. We use a 4 balloon in the TPT. And this is where our initial results, but we still had the sheath in the posterior tibial. That was a 4-5 slender. So then if you look at picture number on the left of the screen, we have a wire that's crossed past the retrograde sheath in the PT, and we did balloon tamponade with a 2.5 balloon. And once we finish, you can see on the right now what the flow looks like. And ultimately, this was final result after opening both the anterior tibial, the TPT, and the posterior tibial artery. So patient was taken back to the OR for a cleanup prior to leaving the hospital. We initiated wound vac, antibiotic, and discharge home. Our protocol is to see a patient within a week or 2 after discharge. But that's when we went on lockdown. So we did his home health and wound care virtually for 3 months prior to seeing him back in clinic. And so this is how we made progress over time and ultimately end up healing his foot after approximately 6 months. And then at times we have patients without options where surgically we cannot offer them anything. And then endovascularly, we have limitations because either multiple failures, recurrent tibial restenosis, extremely calcified arteries, unreconstructible vessels, and from a surgical standpoint, no targets or no conduit, but the foot is still viable. And this we can see in approximately about 20% of CLTI patients. So one of the things that we've been able to look into, see we can offer this patient is deep venous arterialization. The idea is normally we get artery to the capillary bed, but in this patient population, we cannot. And so the vein normally would take blood back to the heart, But in this case, what we do, since the artery cannot reach the foot because of heavy calcification or poor outflow, we create a conduit connecting the artery to the vein, and we just have the vein deliver oxygenated blood to the foot. And so it can be done percutaneously, it can be done surgically, or in a hybrid approach. And the idea is to pressurize the vein, to backfill the capillaries, improve tissue perfusion, and trigger angiogenesis. And so this is the case that was done, we did in 2019, of a lady where you can see her inflow is very good. Common femoral, superficial femoral, profunda, popliteal, all open. She had an intervention where there was a high-grade lesion at the distal popliteal going to the AT, balloon angioplasty, put a drug-eluting coronary stent there. You can see the dorsal pedis is open. However, there's not a good blush because of severe microvascular disease. Perineal is occluded, posterior tibia is occluded. So she has an orphan heel. What we did for her is we connected her TPT artery to the perineal vein. We balloon angioplasty across that fistula, put cover stents, navigate it all the way down to the foot, balloon angioplasty with a scoring balloon to destroy the valve and be able to deliver blood to the foot. So in addition to her anterior tibial and dorsalis pedis, now we have another conduit delivering oxygenated blood. And she did very well. But sometimes we have patients who are truly no options, meaning the smallest cover stent that we can use for those cases are 5 millimeters. But in patients that have vessels that are 2.5 or 3 millimeters, we cannot put a 5 millimeter cover stent to cross from artery to vein because the cover stent is just going to get crunched up from the calcium. So this is a gentleman who came to us with CLTI, was not getting better, came from an outside facility. He had multiple interventions by us opening his anterior tibial, posterior tibial, and perineal. Even though we had him on aspirin, Plavix, and Xarelto, he kept restenosing and thrombosing. And so this is how he presented to us. And the reason why I showed these very difficult pictures is to show that there's still hope, even though a patient presents like this. And so he had osteomyelitis, multiple amputations. And so as you can see, he's really reaching a point where he's about to proceed to a major amputation. And what I also want to point out to you, you can see the calcium of his arteries in addition to the many bony landmarks that are missing. So for this gentleman, he also had chronic kidney disease. We did his case with CO2, so that we're not going to jeopardize his kidney function any further. And when you look here, anterior tibial, it looks small, but just diffuse disease. Same thing with perineum, which is occluded mid-calf, and then the posterior tibia is also occluded. What in red is what's missing. Even though the anterior tibia makes it close to the ankle, there's nothing going to the foot. So this patient does not have any named vessel to his foot. And I mentioned the calcium to you earlier as well, so he has a high MAC score. So what we did for this particular case, we decided we're going to do something else. We did atherectomy of the posterior tibial balloon angioplasty. And we decided we're going to get retrograde access in the lateral plantar vein to make a connection between the two, very much like the case I presented earlier. And so this is how we get lateral plantar access with ultrasound guidance. And we've learned a lot from our radiology technicians to help us out with this. And we always use ultrasound to do that. And then after that, we used the VAST technique where we use 2 snares, 1 snare in the artery, 1 snare in the vein, and we puncture with a 21 gauge needle, insert a wire and pull the wire, and then establish connection between the artery and the vein. But this is a case where the artery was so small that we could not use a cover stent. So we just used balloons. We made a fistula across the connecting the 2 vessels. And here we have now more oxygen in the blood going to his foot. The patient went on to heal 6 months later, but this gentleman without this procedure, I'm sure would have been in trouble. There's a paper we just published not so long ago, this past summer in CCI, a single center, 42 patients, and 60% of them were referred for 6. These are patients historically that we didn't do much. They usually went on to amputation. And our patency at 6 months was 26%. Amputation-free survival was 60.9%, and wound healing was 23%. And you see that discrepancy between patency and amputation-free survival. And so when you look at the 3 pictures at the top, picture number 1 is a patient who presented with no flow to the foot, really without any named vessel. Patient had a common femoral to DP bypass, unfortunately that went down after so many years. And after doing deep venous arterialization on day 1, that's where you see the picture in the middle, with a cover stent deploying blood to the foot. But then when you brought him back a couple of weeks later, look how much blush we've developed over time, luckily from backfilling of the capillaries and angiogenesis, hopefully, but he definitely has more uptake than he had before. And we think that's because of the theory of angiogenesis that happens with deep venous arterialization, but that still needs to be proven. And then what happens when people present with no option and we don't treat them? So this is a preliminary study I presented a link this year, this summer, by one of our colleagues out of Harvard. And Clarity was a single-arm prospective observational study. We participated in this study as well, where we looked at no option CLTI patients that had at least 2 failed endovascular approach and without any surgical option. We just follow them and see what would happen to them. 193 subjects. At 3 months, 13.5 were dead. At 3 months, 33% were amputated. And this is only 3 months. The 6 months data is going to be published or presented at VEITH, I think sometime in the next weeks or so. But it shows you when patients get to this stage, the morbidity and mortality associated with the illness. And we can't talk about CLI. We cannot talk about revascularization without talking about that CLI. It was presented yesterday. Unfortunately, not enough time to really digest the study. But the message here is patients with CLTI can do very well with bypass, especially if a patient is cardiovascularly stable to tolerate surgery, but most importantly, if a patient has a conduit. What they noted was a major adverse limb event were worse with endovascular compared to surgery. A major reintervention was higher with endovascular compared to surgery. And that went on, that was predominantly in patients that had good vein conduits. Without a vein conduit, everything is about the same. But hopefully we're gonna have more discussion, hopefully more time to discuss it in the future. And regarding deep venous arterialization, at Viva, so 2 weeks ago, the data for PROMISE 2, which were among our site, was one of the 20 around the country, was published, and it was approximately, if I'm not mistaken, 66% limb salvage rate at 6 months for a no option patient population, which I just mentioned to you. When nothing's done, they have a 32% amputation rate at 3 months. And I thank you for your attention.
Thank you very much, Dr. Dandu. That was a very, very excellent presentation, and thank you for sharing the very elegant techniques that you use for limb salvage. And again, I think the best CLI data has to be taken with a grain of salt because, it was not that all the centers were employing all these very advanced revascularization techniques, such as yourself, especially like TAMI, or for example, this deep arterial revascularization that is done for no option patients. So I think we'll still, we'll take that with a grain of salt. But again, it is true that, if you have a good conduit, so that is the way to go. Yeah. I have one question from the audience. Yes. So it says, so Ahmed's asking, who's one of our fellows and is endovascular trained, is asking, what is the role of IVUS or imaging in the complex CLTI cases, and how much IVUS or imaging do you employ in your practice? Oh,
thank you very much. That's a phenomenal question. So I use IVUS for every single case. And our colleague, Eric Shemitsky, just published a paper not long ago with the amazing multidisciplinary committee showing how in almost 70% of the time, it changes what you do. And so I can anecdotally say that for the same thing for my practice as well. So we use IVUS for everything, especially dealing with infrapopliteal vessels. Not uncommonly, we want to undersize those vessels, just what we look at with our eyes. So what you think is a 2.5 or 2.0 could be a 4 vessel. And when you look at the amount of volume you can provide a patient when you have a 4 millimeter tube compared to a 2.5 is a big difference. And some of the trouble that we've had in the past with endovascular interventions is undersizing, so we don't provide the best care. And among the many things that are going to also come up even with best CLI, IVUS was not mandatory for endovascular intervention. So were we providing the best endovascular therapy at the time? Those are questions to ask. But IVUS is extremely important. Your SFAs, not uncommonly, you might have an 8 millimeter or 7 millimeter vessel. But if you don't know, you put a 5 millimeter stent, you can foresee the trouble that's going to happen. So I think IVUS is extremely important for these cases.
Great. Also, out of my own curiosity, is there any special aftercare for the DVA patients that something that you tell your podiatry colleagues or wound care colleagues, that is there any special aftercare that should be taken?
Yes. So that's also a very good question. Thank you very much. When it comes to the post-care for deep venous arterialization, since all of us are still learning how to handle and take care of these patients, we work with just a handful of podiatrists for this particular reason. Most importantly, we expect what we call a DVA storm to happen. So they have pain afterwards. Some of them will have a lot of swelling. And so we ask our podiatrists is they have to do any amputation to at least 4 to 6 weeks, enough time for the capillaries to pressurize, to really rise that tissue perfusion to reach a healing threshold, number one. Number two, whatever they do, any kind of amputation, we ask them to do tension-free amputations. So normally, they'll put tourniquets on people when they amputate, but ask them not to do that because the pressure of that tourniquet can potentially shut down the veins that are delivering blood to the foot. And so those are all the intricacies that we do. And then from a pharmacological standpoint, we give everybody a DOAC at a minimum. And then for folks that are low risk of bleeding, we'll do triple therapy, aspirin, Plavix, and DOAC. For those that are high risk, then we'll do at least Plavix and DOAC. What we started doing lately, we'll even test them to make sure that they're Plavix responder, just because these are very difficult procedures. And we don't want to have to deal with thrombosis, which we've dealt with in the past for these patients.
When you say DOAC, do you actually give the 2.5 Xarelto or a full dose of DOAC?
So we'll do full dose. So for our dialysis patients, we use 2.5 Eliquis BID. And for the non-dialysis patient, we use 5 BID of Eliquis.
Okay, great. So we have 2 more questions. Dr. Menegas is asking, how often, CO2 angiography has been used long time, and most of us don't use it. In which cases do you use it to save contrast, and how do you image with it?
Oh, fantastic. Thank you. So CO2, we use a lot of it. And the way we got into this was almost by accident. We have a lot of renal transplant patients, and they would develop CLI, and we wouldn't treat them. And so we decided to get into the CO2 world so we can be on a good side with our nephrologist. And so now we use it more than we even thought we were going to use for. So anybody who has a creatinine clearance less than 60, we put CO2 on the table. And we have a software where we can do stacking of our images. So you do a cine, but it superimposes all your frame into one to make it easier for you to visualize. We give nitroglycerin, and between each image, we have at least 45 seconds for CO2 to wash out so we can get a good picture. But we do a lot of cases with CO2. We even do deep venous arterialization with CO2 sometime, or sometimes we combine. But so when we get phone calls about, an 85-year-old with creatinine of 2, we say, bring him, we'll take care of them. So it's been really a game changer for us to be able to provide care to a group of patients who historically we've shied away from taking care of them.
Excellent. And my own experience was that the CO2 bilirubin is usually very painful. We used to use it for like SFAs and bigger vessels, and bilirubin, I thought the patients were they were very uncomfortable, and as soon as they would move, the PSA would become basically a no-go. So have you not experienced that?
Yes, in the beginning we experienced that, and one thing we've done is we'll collaborate with our anesthesiologists. And so what they do for us is, for those patients, sometimes we'll do a femoral and popliteal nerve block. Mm-hmm. And so they use a short-acting agent that will last about 90 minutes, but most of those patients also have peripheral neuropathy. Mm-hmm. So when we do that, the leg is paralyzed for a good 3 hours, so we can take CO2 images without moving, and we can complete a case that way.
Got it. Excellent. All right, so regarding the direct SFA sticks, Dr. Latif is asking whether, what do you use for vessel closure, whether you use manual compression or a vascular closure device?
For direct SFA stick, we get everything with ultrasound, most importantly, just to make sure we can puncture area where there's not a whole lot of calcium. We want to make sure even though it's SFA, but it's still compressible. So we test that with our probe before we get access. And if the vessel is greater than 6 millimeters, we tend to put a closure device. And we predominantly use suture base. So we use the perclose for the most common.
Yeah. All right, very good. And then Dr. Bortnick is asking if you use any PCSK inhibitors for CLI. Is there any data on PCSK9 inhibition for CLI for Revasc?
Yes. So any patient that we approach, we want to make sure that we're treating them according to the guidelines. So we want to get a LDL less than 70. So we go high dose statin therapy if they can tolerate it. If they cannot, we combine it. For those that cannot tolerate statin, we use PSK for all of them. So Repatha or Praluent, whichever the insurance will cover. But yes, we use it very, very frequently.
And oh, thank you. Dr. Menegas has a question. I'll unmute Dr. Menegas. Go ahead. Mark?
I'm sorry?
I thought there was a hand that was raised.
No, it was the CO2 question.
Okay, got it. Okay, all right. Sounds good. All right, very good. Excellent. I believe that is all the questions we have. Thank you very much. Unless there's anything else, any other burning issues, I think this was very insightful and excellent talk. Thank you very much for spending the morning with us, and we'll have you back soon again. Thank you.
Great. No, thank you very much for having me. This was definitely a pleasure and an honor. And hopefully, as we all continue working together across specialties, across regions of the country, hopefully we can know to deliver better care to our patients. Thank you very much.
Thanks a lot. Have a good day.
Great.
Thank you.
Thank you.
Thank you.